Hello, we are going to discuss about melanoma, right? So first, malignant melanoma, it's a malignant tumor arising from the epidermal melanocyte. It comprises of only 5% of the skin cancer, but accounts for 75% of the mortality. So it's the fifth most common newly diagnosed malignancy in men and the seventh most in women. So what are the sites of occurrence? It can be in skin, mucosa, uveal tract, and meninges. And what is the epidemiology? So here, epidemiology, it all races incidence will be around 24 in 10,000 people, but white people it's 28.5 and black it's 1.1. In India, the incidence is zero point 0.5 per 1 lakh people. So peak age of incidence is seventh decade, and male to female it's 1.6 is to 1. So females exceed males before 45 years and the incidence increases in latter after 45 years. In Western population, the sole of feet and internal mucosal membrane are the major anatomical sites affected in Indians. And in Western population, upper back is the most common site, then trunk in men and lower extremities in women. Okay, so what are the risk factors for malignant melanoma? It can be ultraviolet radiation exposure, PUVA therapy, skin phototype 1, 2, multiple or severe sunburns, melanocytic nevus, then congenital melanocytic nevus present, family history of melanoma, and immunosuppression. So increased exposure to UV radiation is considered to be a major risk factor for the increased incidence of melanoma. Sunburns are a risk factor. Sunburns are primarily due to UVB radiation. But UVA radiation plays a greater role in melanoma pathogenesis. Right. So individuals with recreational and vacational sun exposure have greater risk than with constant occupational sun exposure. So continuous UV exposure is either in adult life or during adolescence seems to play a protective role. Okay. Next is PUVA therapy. An increased risk of melanoma is observed beginning 15 years after the first exposure to PUVA. So risk was greater in patients exposed to high doses appear to be increasing with time. So this lower skin Fitzpatrick type, multiple or severe burns, melanocytic nevi, congenital melanocytic nevus, family history of melanoma, immunosuppression, all these are risk factors. Now, what is the etiopathogenesis? So, overexpression of proto-oncogenes or mutations in tumor suppressor genes. So, UV radiation, UVA and UVB will cause DNA damage. So, direct DNA damage will happen, and indirect damage via reactive oxygen species. Then there will be cellular effects like mutations in proto-oncogenes, inactivation of tumor suppressor genes, and genomic instability and carcinogenesis will happen. Immunosuppression will also happen, and because of decreased tumor immune surveillance, also this can go on. Now, what are the genetics of melanoma? In a normal melanocyte, the cell cycle is tightly regulated by poor regulation of growth promoter genes and tumor suppressor genes. So these are the different genes that are involved: the CDKN2A, P16, CDK4, BRAF, RAS, KIT, NF1, TERT, okay, at least this much. Okay, so CDKN2A is a tumor suppressor gene. It will inhibit, and even P60 actually inhibits CDK4. So CDK4 is cyclin-dependent kinase. So if there's a loss of function of these two and activating mutation of CDK4, BRAF, that will go towards melanoma. So CDKN2 and P16 are involved in hereditary melanoma type, and these are cutaneous melanoma. Okay, right. Now RAS signaling pathway, the growth factors like receptor tyrosine kinase um, will go activate the receptor tyrosine kinase, and RAS is activated, RAF is activated, MEK, ERK, and there will be cell proliferation and survival. So what is happening here? CDKN2A will inhibit CDK4, CDKN2A will inhibit MDM2, So CDK46 actually should have been activating RB, then E2F, and there will be cell cycle progression. So this is a CDK in 2A, CDK4, P53 pathway. Okay, next let us look at the clinical features. So classification of malignant melanoma, there is superficial spreading melanoma, nodular melanoma, lentigo maligna melanoma, acral lentiginous melanoma, okay, including subungual melanoma. Then we have desmoplastic melanoma, mucosal melanoma, nevoid melanoma, and spitzoid melanoma. So most of them is superficial spreading melanoma, right? But acral lentiginous melanoma is more common in Asians. So what is this Ackermann concept? There are two growth phases. Normal melanocyte, there will be a radial growth phase and a vertical growth phase. So radial growth phase is horizontal, it will be intraepidermal. There will be a pagetoid spread. Also micro-invasion into the papillary dermis can happen. So regression may be present and it has excellent prognosis. Now when there's a vertical growth phase, this cohesive nest nodules or plaques will be in the dermis and there will be lymphovascular invasion and there can be metastatic spread and metastatic melanoma can occur. Now let us see the prognostic factors. So we can think of clinical prognosis, tumor-related prognosis, histological prognosis, and others. So clinically, based on the age, sex, site of the primary tumor, like if it's like in the back, upper arm, neck, and scalp, it's high risk site, but poor prognosis is with the acral sites. Now, tumor related, like if the breast lobe thickness, Clark level, growth phase if it is vertical as compared to radial, ulceration, and mitotic rate. Okay, histological if there is lymphovascular invasion, perineural invasion, regression, microsatellitosis, and tumor infiltrating lymphocytes. Then others are like immunosuppression, increased number of nevi, family history, previous melanoma, congenital giant nevus. So what is the ABCDE rule? So A is asymmetry, B is border irregularity, C is color variation, D is diameter more than 6 millimeter, and E is evolution. Right. So what's the ABCD rule? A is asymmetry, B is border, C is color variation, D is diameter more than 6 millimeter, and E is evolution. So what is Glasgow 7-point checklist? If there is change in size, its shape, color, diameter more than 7 mm, inflammation, oozing, and change in sensation. Okay. Now let us see the clinical pathological correlation of the major variants. That is superficial spreading melanoma, nodular melanoma, lentigo maligna melanoma, then acral lentiginous melanoma. So most common is SSM, but ALM is more common in Asians. The site, intermittently sun exposed skin, like lower extremities in the site of SSM is more on the lower extremities in females, upper back in males. It happens in middle to elderly age group. Sun exposure, intermittent intense exposure is required, like when you go to the beach and all. So BRAF mutation is important. Then the clinical features, there will be flat, scaly, macule or patch, irregular borders, variegated colors, and hypopigmented areas of regression. What's the histopathology? There is asymmetrical atypical melanocytes scattered throughout the epidermis. So there is buckshot scatter, right, in histopathology. Then dermoscopy, there is atypical pigment network, irregular dots, globules, streaks, and regression areas. What is the differential diagnosis? We can think of dysplastic nevus, junctional nevus, junctional spitz nevus, right? Bowen's, vegetoid Bowen's, Paget's disease. Next is nodular melanoma. It also occurs in the trunk. It also is because of intermittent sun exposure and BRAF mutation is involved. Rapidly growing raised nodular plaque, uniformly dark blue, black, or bluish red with or without ulceration. And 5% of them can be amelanotic. So histopathology, there will be no um, radial growth phase. So uh, dermal tumor is composed of oval or round epithelioid cells and epidermal invasion may be present. Blue-black structureless areas is found in dermoscopy. So polymorphous vessels can also be found. So what are your DDs for nodular melanoma? Atypical compound nevus, pitch nevus. Now lentigo maligna uh, melanoma. What do you? It's in the chronically sun-exposed sites like face, cheek, nose, and all. So it occurs in elderly. Here, chronic cumulative exposure is important. So c-KIT mutation is involved. It is like initially a flat, slow, enlarging brown macule, lentigo maligna, irregular shape, variegated brown shades on photodamaged skin. So histopathology, there will be atypical melanocyte along the dermoepidermal junction involving hair follicle and sweat ducts, atrophic epidermis and solar elastosis. So dermoscopy, there is rhomboid structures, annular or granular pattern regression areas will be there. Dysplastic nevus and solar lentigo are the differentials. Hmm. So solar elastosis will be present a lot in lentigo maligna melanoma because of the chronic cumulative sun exposure. Now, ALM is more common in Asians. It's found in sole, palm, subungual areas, in the not sun-exposed areas. So it's not related to sun exposure actually. Any age it can occur. BRAF mutation is important. So brown to black macules with irregular borders progress to vertical growth, often ulcerated. So basal atypical melanocyte will be there. Acanthosis, elongated ritty ridges, nest at the tip, and deep extension to sweat glands and neurotropism will be there. So there will be parallel ridge pattern and irregular dots and globules. Structureless areas will be there. What will be a differential? So obviously plantar what? Hematoma, benign melanocytic nevus. So this almost we know, right? So NF1 mutation can be related to desmoplastic melanoma. Hutchinson sign is seen in subungual melanoma. Best prognostic factor is the breast flow thickness. Okay. Mm. So we already went through all these. Um, this is a flat, scaly, macular patch, irregular borders, asymmetry, variegated colors. Here it's a rapidly evolving, raised nodule or plaque, dome shaped, uniformly blue, black, or reddish color. Here, this LMM will be flat, slowly enlarging brown macule. Areas of hypopigmentation, like regression, might be there. Lentigo maligna, it is, you know where it is found. I mean, sorry, ALM, this acral lentiginous melanoma, you know where it is found. So there will be buckshot scatter here. Here, a lot of vertical growth actually. And here, atypical melanocyte along the dermoepidermal junction, and it can involve the hair follicle and sebaceous glands. Here, irregular epidermal hyperplasia, acanthosis, elongated reticulus, atypical spindle melanocyte along the basal layer. So dermoscopy, some pigment network, here blue-black structureless areas, rhomboid structures, parallel ridge pattern, and irregular dots and globules can be found. Now other types are there like subacqueal melanoma. It's a subtype of acral indigenous melanoma. It arises from the nail matrix. So great toe or is involved more than the thumb obviously, and wide, dark or irregularly pigmented longitudinal band would be there, and may show nail dystrophy or nail plate elevation. Hutchinson sign, there is pigmentation of the proximal nail fold will be present, and ulceration in the advanced cases can be there. So clues suggesting of malignancies: age more than 40 years, bandwidth more than 3 mm, irregular border with variegated color, and rapid increase in width. Nail dystrophy, Hutchinson sign in ulceration and bleeding. So differential diagnosis: this benign longitudinal melanoma, melanocytic nevus, subungual hematoma, and onychomycosis. Bandwidth more than 3 mm is important here. So these are the clues suggesting here: the age, bandwidth, the irregular border, rapid increase in width, ulceration, bleeding, Hutchinson sign, nail dystrophy. Next is desmoplastic melanoma. It occurs in 6th to 7th decade, sun-exposed head and neck area. Firm sclerotic indurated plaque or nodule will be there. Half of the lesions are amelanotic. So slowly growing but locally aggressive one. It is due to NF1 mutation. Um, so The spindle-shaped melanoma cells in the densely collagenous stroma, it will be found. Perineural infiltration is common, and lymphovascular invasion is rare. Poor lymph node metastasis, but high local recurrence can be there. Dermoscopy, there will be structureless white scar-like area, polymorphous vessels, and peripheral brown streaks can be sometimes present. So differential diagnosis will be scar, morphea, dermatofibroma, and neurofibroma, desmoplastic nevus. Now mucosal melanoma is there, nevoid melanoma, spitzoid nevus. Okay, and there are some other important variants also. So mucosal melanoma, you know where it is found. Clinical features are pigmented amelanotic macule, nodule mass will be there, early bleeding, ulceration can be there. Histopathology, there will be atypical melanocyte in the basal layer and nest in the lamina propria. Junctional activity may be absent. High mitotic rate and vascular invasion is common. So differential diagnosis is pigmented mucosal macule or melanoma arising in the nevus, Kaposi sarcoma, and mucosal nevus. Now, nevoid melanoma. It resembles a melanocytic nevus clinically, usually small, may show recent change in size or color. Histopathology, there is nested pattern resembling a nevus. Cells show atopia or high mitosis, lacks maturation with the depth, deep extension, and poor circumscription. Common, so nevoid melanoma, you can think of differentials such as common melanocytic nevus and dysplastic nevus. Now, spitzoid melanoma. It presents in younger age, so nodular or papillary lesion often pigmented. Spitzoid cells, large epithelioid or spindle cells with abundant eosinophilic cytoplasm may be pigmented. Camino bodies will be present and asymmetrical, mitotically active, lack maturation. So, spitzoid melanoma ka differential diagnosis Spitz nevus and atypical Spitz tumor. Then there are other important variants such as basal cell melanoma, small cell melanoma, clear cell melanoma, and signet ring cell melanoma. Rhabdoid melanoma, myxoid melanoma, malignant blue melanoma, metaplastic melanoma, pigment synthesizing melanoma, and epidermotropic metastatic melanoma. Okay, this is done. Histology we already went through. Immunohistochemistry. Then histological report essential parameters like we have to tell the type of melanoma, breast flow thickness, Clark level, ulceration, mitotic rate, microsatellitosis, lymphovascular invasion, perineural invasion, regression, tumor infiltrating lymphocyte, margins of the lateral and deep, pathological state, additional findings. Now prognostic features: this breast flow thickness, ulceration, high mitotic rate, lymphovascular invasion, perineal invasion, older age, head and neck location, male sex, absence of uh, TIL, microsatellitosis, and vertical growth phase. So immunohistochemistry, these are the immunohistochemistry. S100, SOX10, S100 will be present in nucleus and cytoplasm. SOX10 will be present in nucleus. HMB45 in cytoplasm. MART1 in cytoplasm. MITF, Ki67, cyclin D1, right? So S100 is sensitive but not specific. SOX10 is the most useful in desmoplastic melanoma. Then HMB45 is negative in desmoplastic melanoma. Okay, breast flow thickness is single most important prognostic factor. So tumor host interaction, there will be tumor infiltrating lymphocytes, lymphovascular invasion, perineural invasion. Okay, let us see the clinical diagnosis. We have this ABCD rule and Glasgow checklist and ugly duckling syndrome. The lesion looks different from other nevi of the patient. Dermoscopy we already went through. Investigation, we have to do a complete skin examination, dermoscopy, excisional biopsy is preferred, incisional punch biopsy if it's a large lesion, and routine histopathology with IHC, baseline blood test, imaging as per stage like chest X-ray, HRCT, ultrasound CT, MRI, PET CT, central lymph node biopsy in indicated cases. Now staging. So TIS is melanoma in situ, no lymph node. So stage 0, 1, 2, 3, 4 is there. So stage let us see, here it is N0, here it is M1. So when nodes are involved at stage 3, when metastasis is involved is M1. Here it is just T1, T2. Here is T2, T3, T4. Okay. So surgical management. If breast low thickness, if it's just in situ, just 0.5 to 1 centimeters required. Less than 1 mm, 1 centimeter. 2 mm, 2 centimeter. 4 mm, also 2 centimeter. More than 4 mm, also 2 centimeter. Hmm. Okay. So sentinel lymph node biopsy is recommended for T1B. Okay. That is more than 0.0 mm to T4 melanomas. Provides accurate staging and prognostic information. Then wide local excision is required for primary treatment of localized disease and regional lymph node dissection also. Systemic management, we can try some immunotherapy like anti-PD-1, anti-CTLA-4, anti-PD-1 like nivolumab and pembrolizumab. Anti-CTLA-4 is ipilimumab. Then combination therapy of PD-1 plus CTLA-4 in advanced or metastatic cases. Now, targeted therapy for BRAF mutant melanoma is there. BRAF E600 mutation, if it is there, we can try dabrafenib and vemurafenib. MEK inhibitors like trametinib and cobimetinib can be tried. Other options are KIT inhibitors can be tried. Clinical trials and novel agents are there. Radiotherapy, chemopalliative in selected cases. So follow up. First 2 years every 6 monthly, then next 3 years every 6 to 12 monthly. Thereafter, every annually is enough. Full skin examination has to be done. Sun protection, we have to avoid sun exposure from 10 a.m. to 4 p.m. Protective clothes, broad spectrum sunscreen is required, and avoid tanning beds. Then management algorithm, like if there's a suspicious pigmented lesion, dermoscopic evaluation, excisional biopsy, histopath IHC, stage it, then treatment according to if it's localized or advanced. Right, so this is kind of very high yield facts. Thanks for listening.